Hi, I am Brandy. I'm doing this video to help others like me. I was trying to study today and wanted to just listen to some things on YouTube about fetal well-being and maternal nursing, and I couldn't because I couldn't find anything. So I decided that I would help others by recording the things that I've learned and try to explain it in the best way that I know how. Like I said, I do have 3 children, so if you hear anything in the background, just ignore it. That's what I have to do. It's very hard to study. But anyways, first thing that we're going to talk about is fetal well-being. That's the chapter that I'm doing. Yes, dear. The first thing on there is diagnostic testing, which is typically used for 2 main reasons. The first reason is for dating, which tells you how far along the mom is and how old the fetus is, obviously. The second thing is to check on the well-being of the fetus and check for any abnormalities in the fetus. Ultrasound is what everybody's mostly familiar with as far as diagnostic testing goes. It's very non-invasive for the mom, typically poses no risks whatsoever. The key to that, though, is that for as far as dating goes, it is typically not accurate past 12 weeks because the baby's moving around too much. Mostly ultrasound is done from 16 to 20 weeks, which is routine. If there's any first trimester bleeding, then they'll do extra ultrasounds, or if there's a high-risk pregnancy, extra ultrasounds will be done. Typically, the sex of the baby is found out around 16 to 20 weeks as well. In your first trimester dating, they're always going to measure the crown to rump, which is pretty accurate in telling you how far along mom is. And to do that, you're going to take how many centimeters plus 6.5, which will equal how many weeks gestation the baby is. After 12 weeks, like I said, the fetal movement prevents the baby from being accurate on your dating. So you want to do it up until 12 weeks, and that's it. For your second trimester dating, you're going to go by the femur length. And then after 26 weeks, which is when the mom is into her third trimester, it's really hard to do accurate dating by ultrasound or whatever, because the growth rate of the fetus it differentiates so much between babies. One of the other things that is a diagnostic testing, which isn't done very often, is fetal scalp sampling. I don't think that this is going to really be a lot on our test, but I just wanted to throw it in there that it is a diagnostic test. The next one mentioned is a biophysical profile. And the reasons that you would do this are for decreased fetal movement, premature rupture of membranes, and that sort of thing. It's based on a scoring profile. So your normal scores are going to be anywhere from 8 to 10. Anything below 6 is not a good sign, and then anything 4 and below is really bad. Deliver baby now. So it is based on your breathing, your body movements, muscle tone, and the amount of amniotic fluid. And you get 2 points for each, so that's how it's scored. Next type of diagnostics is external fetal monitoring, or EFM. It'll tell you the uterine activity, it'll tell you the baseline fetal heart rate, and it'll show you any D cells or A cells. On your uterine activity, what you want to look for is the frequency, the duration, and the intensity. How often, how long, and how hard are the contractions. You also want to make sure that there's variability in your fetal heart rate. Let's see. For your monitoring equipment, typically what you'll see is the ultrasound transducer, which is external, emits sound waves, and that goes on the outside of mom's belly. It's only good for doing long-term variability. which means that you have to see like a 10-minute strip to be able to get accurate information out of it. The next one that is monitoring is a spiral electrode, which is screwed into baby's scalp, and that can do either short or long time variability. You'll usually see these used when the mother is extremely obese and you cannot pick up a good heart rhythm on baby, or also if you're having difficulties with the baby, or also if there are twins or multiples. That way you can pick up separate heart rates. You can only do this if the membranes have been ruptured and as long as mom is dilated at least to 2 centimeters. Also, a good thing, like our instructors mentioned, was that the presenting part, which means the head, because it has to be screwed into the head, has got to be down there. So if baby's breech, obviously you don't want to screw it into a foot or a butt. Your fetal heart rate says that it's best evaluated between contractions and asks why. Well, obviously when the uterus is contracting, it's going to affect baby. So you want a true fetal heart rate, one that's not affected by the contractions, which is why you're not going to do it while a contraction is going on. Your baseline is the average for a 10-minute period. Normal is going to be from 110 to 160. Anything below that is Brady. Anything over that is tacky. Now, when the baby gets older and the fetus is getting bigger, it can't move around as much, which means that the heart rate's going to go down a little bit. That makes sense. If you're not moving around, your heart rate's not as fast. Then it talks about heart rate changes, either periodic or non-periodic. Periodic just means that it occurs with the uterine contractions. Non-periodic means it has nothing to do with the uterine contractions. Like I said earlier, tachycardia is anything above 160. So when you're looking at your nursing questions and it says, which of these things is of concern, you always want to look at that. If it's above 160 or below 110, that's your thing that you're going to be concerned about. Heart rate's not right. Yes, these things can happen for short periods of time and it's just, something normal. But if it happens for a long period of time, there's an issue. One of the things that our instructors talked about was that if the heart rate was tachycardic on baby, then one of the things you needed to check first was mom's temperature. So some of the causes of tachycardia are going to be infection, fever in mom, but also it can be hypoxia and heart failure, those sort of things. But always remember, the first thing you need to do is check mom's temperature. Also, one of the things you'll hear over and over and over again in this chapter is to change positions of mom. That will help on almost everything in here. So again, tachycardia, take mom's temperature and change positions of mom. Bradycardia is less than 110, like I said, which if the variability decreases, that's what's called an ominous sign. Ominous means it's a warning sign. It's scary. You need to monitor baby very well, see what's going on with baby. Some of the drugs that you can give mom for different reasons can cause the bradycardia. Things like anesthesia that drop mom's blood pressure will also cause baby to become bradycardic. Prolonged cord compression can also cause bradycardia. And when you really want to, when it's severe, is anything less than 80, and that's where you're going, okay, so we talked about variability. You always want variability in your monitor strips. Always. Variability, when I think about that, is I think about the baby moving. If baby is active, baby is good. So anytime you're going to have an active, well baby, you're going to see variability. If baby's health starts to decline, baby will not be as active and you will see less variability. So if you look at that line and you see it jumping all over the place, you know that baby's active. Anytime you have decreased variability, excluding sleep cycles, it's not a good sign. The actual definition for variability is the cardiac rhythm of the fetus. So like I said, it's related to the fetal activity. And you have to remember that it will decrease as baby sleeps because baby's not moving. Baby's brain is not working as much as it is when it's asleep or when it's awake and moving around. So it's going to be lighter. And that typically will range anywhere from 20 to 40 minutes for the sleep cycle. Variability short term reflects the O2 reserve and is normal. When you have variability long term, that's when you see your waves and your cycling. It's your difference between your lowest and your highest fetal heart rate in each cycle per minute. So you want 3 to 5 cycles per minute with a change of 6 to 10 beats per minute. So one little square equals 5 on your beats per minute as far as your amplitude change, excuse me. So you want your amplitude change to be at least bigger than at least 1 square. And again, that's going to change with the fetal sleep cycles.